Perfect. So my name's Georgina Kontny. I'm one of the A&E consultants up at the Royal Liverpool Hospital. And I'm going to quite briefly now just share the journey that my department's been on over the last couple of years regarding mental health and quality improvement. So essentially, when you come to an RChem day like this, we see loads of great practice, loads of inspirational speakers, and that's what I've taken away from there. I've made loads of notes and loads of things that I'm going to try and copy and paste into my department. But we don't often see departments like mine. So I'm at the other end where the care that we provide our patients, or at least at the very start of this QIP, is actually really poor. And although you come to these places and you see these aspirational ideas, you go away with all the best intentions, but worry about how you're going to fill that gap, how you're going to get from where you are currently to these brilliant gold standards across the country. So what I'm going to show is sort of hopefully how we went from absolutely awful to slightly better. The problem we were faced with, I kept it quite broad when I started my QI project, and it was off the back of many serious incidents where patients had had a really poor experience in my ED and some really devastating outcomes. And we wanted to look at the quality of care that all the patients in mental health crisis were receiving in our A&E. We used the last RChem quality improvement in mental health and self-harm as a basis, looked at the standards that were set out there, a lot of which have been carried forward into this current iteration, and also used the mental health toolkit that's provided by RChem and subsequently been updated to sort of see what we should be achieving. And we also did a staff survey and a patient survey, so anonymously via Google Forms, to get some feedback about what the staff and patients thought were the true issues within the department, as well as just following the sort of KPIs and the targets that we set ourselves. It's quite embarrassing to even share how awful we were at the start. So as was alluded to earlier, there was a time frame attached to the sort of risk assessment at triage of less than 15 minutes. We scrapped that because we were virtually 0% on that. But when we just got rid of the time frame, just that whether patients had had a mental health risk assessment completed at triage, we were doing that for less than a quarter of our patients. And actually going on to having a mental health risk assessment complete at any point during their inpatient stay with us in ED, even if they'd been seen by the mental health team, we were still achieving that in less than half our patients. I'm not going to bore you with loads of statistics about my department, because the whole idea is that we're all different and we're all starting from our different starting points. But this national QIP gives a great resource to try and benchmark where you're at so that you can compare yourselves going forward over the next few years. One thing that I did find useful and might be useful for yourselves is about the staff and patient surveys that we did. They actually threw up quite a few issues that for me weren't being flagged, that I didn't realise. So if you asked me what the issues were, it would be all about the long delays for mental health beds and all the serious incidents I was answering. But there was a lot of concern about the environment the patients were being kept in, the lack of support and training that the ED nursing staff felt they had, and also the challenges that they were finding to providing observation to these patients. The patients were far less scathing of us actually in their feedback, and actually much more positive. But there were still some really saddening comments about feeling abandoned in the waiting area and poor communication. Off the back of this, we did several interventions. So the first sort of minor ones, which were relatively easy to put in, we made our risk assessment easier to use and made it electronic. So we're a paper light trust, so we still have paper charts for patients, but a lot of what we do is electronic. So the triage is electronic, in the patient notes, but our mental health risk assessment was still a paper form. It was relatively easy just to put that online, and that automatically got our figures up quite a lot. Got rid of some of the barriers about sort of, oh, where were the forms kept, and oh, who's printed them out, are they stocked up, and those easier barriers to stop people doing it. A lot around education, and we found that was a key point, that a lot of the staff in ED, both medical and nursing, felt underskilled in this area and dealing with this cohort of patients, and we've tried to address that. And one of the key things from the staff survey was actually identifying people within our department who have a passion for mental health, and be that through personal experience or lived experience with families, loved ones, patients, but actually really were keen to get involved in a project. And they've been really beneficial as this has moved forward to try and keep driving positive change. It was clear from some of the feedback and some of the comments by staff that actually we needed to do more than just these little changes. The culture in my department was wrong, and there's still a long way to go with that. Some of the comments about why mental health patients should be given a dedicated area, why mental health team aren't just taking over these patients, why we should be doing anything for them, and some of the language used by my colleagues was really shocking and just highlighted to me how much stigma there is still around mental health care and how much work there is to do. When I set up with this project, I had no idea that I was going to be creating a whole sort of hub within the department, whole area. It was not what I set out to do, but I think that's the joy of QIP, isn't it? You get the data at the start and you follow the data, you see where those issues are and you try and make things to try and improve it. So we ended up creating a whole area within the middle of our department. It's an area in addition to our 136 room and our crisis room, which for our highest risk, most agitated patients, but with dedicated cubicles, with safe, comfortable furniture, access to support material, so leaflets, information, and it's staffed by practitioners from the mental health team, support workers and ED nurses to try and provide a safe space for these patients to wait for their full assessment and hopefully get some benefit and some therapy along the way. Result-wise, I've only shared a few sort of iterations with you here, but essentially we went from 23% initially of patients having a risk assessment at triage to 58% after we made it all electronic and trying to reduce some of those barriers with visual prompts and some education, up to around 83% once we launched the hub area. And I'm pleased to say we've been pretty static around the area. And there's been lots of other improvements across the board, and absconsion rates actually decreased massively to bring it more in line with our general population within ED. One of the great things though was the feedback from the staff and the patients. And this is often the things that's hard to quantify when you do a QIP and when you look at data, actually the experience these patients are getting and actually how supportive the staff feel in caring for them. And it helped make a real massive improvement across the board on that. One of the big challenges now is sort of maintaining that improvement and actually working towards a lot of the other things in this QIP that's been launched by RCAM that we're still falling short on. But we've managed to sort of embed an education structure with regular staff training days for all our new starter nursing staff and also the junior doctors in each rotation. And the link teams helping really build bonds between the psychiatric services and the ED services so that we can try and nip problems in the bud and move things forward. We're still faced with a lot of the challenges that many of you will be with staffing the area when we're short-staffed, when we're sort of expanding our footprint into corridors and into the back of ambulances, where we find the nurses to care for all these extra patients, and also trying to make sure that this space is kept for the mental health patients and not infringed by other patients in the department when we're so fighting for space. But overall, we're managing to make positive strides at the Royal. One of the great things that's happened, so 2 weeks today, we moved into a brand new hospital. And because the hub, the mental health area, was part of the footprint of the old hospital towards the end of our time there, actually it meant that in the new build, we've now got a designated area that was part of the design. So instead of just being an old miners area, which has been refurbished, we've managed to have a purpose-built area, which is brilliant for the patients that are coming through the department. So what I would say is our journey is still ongoing. There's still a long way to go. We've gone from absolutely awful to not too bad. But there were a lot of comments along the way about it being pie in the sky and unachievable. But what I'd say to all of you here today is dream big for your departments. You guys are all on this call because you're passionate about either mental health or quality improvement. And there is so much that can be improved across the country in all your EDs. So aim for the stars, get involved with the RCAM QIP. What it will do is give you a benchmark of where you are and give you some great resources like the ones that we've been shared today that we can sort of hopefully share good practice across the trust. And good luck in all your projects.
Wow, thanks for that, Gina. Very inspiring. And I hope that has inspired others as well. It certainly has me. Okay, so we've got 15 minutes left. And I guess we should just open the floor up to questions now. There's been a lot of questions in the chat, and I would say to colleagues who are in the mental health subcommittee that maybe we sit down together and try and work through some of those questions and try and send people some answers to that. to their questions, but also just to say to everybody, we are going to try and send you out attendance certificates for today. And if you would like one, then please pop your email in the chat, and Ali will send you an attendance certificate, which I think would be great for everybody's portfolio. And it's been a really informative day. So I'm just going to open it up now to questions. I guess raise your hand or speak out. Lots of people writing their email addresses, which is brilliant. So Carl.
It's actually Carly.
Oh, sorry, Carly.
So that's my EDU. It's actually that's my default login. So yeah, no, I'm Carly, clearly. I think I put it in the chat there. I think it's been a really, really fantastic morning, and thank you so much for extending the invitation. I'd put it a bit earlier in the chat, but how do we move on from here in terms of making sure that we can kind of continue to share ideas, to communicate together? We've got the WhatsApp group, and I didn't know whether or not that would be the best way, or whether there's a specific database within the Royal College of Emergency Medicine that we should be on.
I will take that forward to the committee and see what we can do, because if there's like-minded people that are interested in sort of making sure we keep talking to each other rather than just occasional newsletters, then actually that's brilliant for me. So we'll look into what the best platform will be. So thank you for asking that. Any other questions? How do you become a committee member? So effectively there was a call out. Stop it, Gina. There was a call out for new members. So effectively there is a time scale as to how long people can be on. So we will put another call out when the next group needs to be sort of replaced. Hillary.
Hey Mark, nice to see you.
Nice to see you again.
And Barbara and everyone else. Yeah, it's a quick question about involving parallel assessment. So yeah, on a number of occasions, I've had pushback from, in fact, bed managers in mental health trusts asking what the blood results are or what a scan shows for a patient before accepting them to a bed. I've managed successfully to push back on that. In terms of saying, well, I'm the clinician that's assessed the patient, I'll decide what they need, rather than the bed manager in a remote trust. I'm just wondering if this is happening anywhere else. To anybody else? It's not a local mental health trust, it's when the patient's going out of area.
Well, at the end of the day, you... Sorry, carry on.
I was going to say, Hills, this happens quite a lot to us in London, and often it's what's happening is that the notes that are being written by the ED clinician are going to often a junior doctor, I think, on the mental health trust, who's feeling a sense of sort of slight panic, mainly because obviously that when they're in that mental health trust, they are quite alone and quite scared around physical health stuff. One of the things that we've done to try and improve on that is actually give those clinicians in the mental health trust who are going to be receiving that patient access to the ED clinician, so we can have a conversation, because it can feel terribly frustrating when you know, as a consultant, you've seen a patient and you think this person doesn't need blood tests and doesn't need a scan, and then a junior doctor at the mental health trust is effectively insisting on it before they arrive. And often found that just a conversation, because you've actually seen the patient, can be reassuring to them. And it kind of stops the demands that come across from bed managers. But listen, it's not perfect. And I'm not sure that there's an actual answer for it, other than obviously, you know, in terms of trusted assessments is something that's very familiar to mental health colleagues, but also they need to trust our assessment.
Yeah. Thanks.
Nirmal.
Thank you, Barbara, and thank you, Mark, and all involved. A really useful day, and especially with your input with regards to the QIP and also Kathleen. Just 2 questions. You know, the pod you spoke about, is it something that you can build into an existing room that has been set up, or it's something you got to build from the scratch? And how many people do you have? Is it one at a time inside that room?
So I was going to ask Mark, who's obviously got experience of it. So the bean bag is called the pod, and you could put it theoretically in any space. It's heavy and it's large, so it sort of lends itself to be sitting in a assessment space, if you like. But maybe Mark, I could see on the chat that you've got experience of it. I wonder if you're still on, you might be able to share what it's like in real life.
Yeah, hi. Yeah, we've recently got a few of these in Leicester after we visited another trust with our sort of security people. They're really comfortable, large bean bags. They're a little bit heavy, but fairly easy to, reasonable to pick up with one person. We're just sort of putting them in a sort of central sort of store for use around our emergency floor at the moment. They're very comfortable patients. They're actually very easy to restrain people on as well if it gets to that stage. And I know I've been thrown on the chair several times myself to practice that. Yeah, and I will try and get a video, because I think we're doing some training in a week or two's time, sent across of their use, so you can distribute that around. I would recommend them. I think they're a lot nicer than the mental health furniture, and they do look a bit more resilient as well, but I'll wait till we get little bits of polystyrene or whatever's in them scattered around a room one day. I'm sure that'll happen.
Thanks, Mark. Nirmal, your other question.
Yes, it is with regards to the search policy. I mean, I couldn't go through in detail. The one for children is slightly different to the adult. Correct me if I'm wrong. It's if the child does not have capacity, as per the flow chart, it says you can't screen them. Whereas in an adult, you could go ahead and screen them if they don't have the capacity. Am I right in saying that, or have I got it wrong?
No, so I think the legal frameworks behind it are the same regardless of your age in terms of capacity. But obviously, capacity is potentially assessed slightly different. Well, it is assessed differently in children. There's also the issue of responsible carers or guardians who can give capacity on consent on behalf of a child. And it was really demonstrating, so the basic principles are the same, and they've pulled bits out of the main policy, but it's their focus on the fact that if the young person says no, unless there is a really grave risk or there has already been some self-harm such that they believe that there is an implement that will be used again, then their default position is that least restrictive option when you compare having someone in the room directly supervising them all the time, as opposed to getting people to potentially have to restrain them if they're really resistant to it, to physically lay hands on and search them. So it's, the principles are the same, and if we needed to use Capacity Act, or if there was a young person formally detained under the Mental Health Act, then we would use all those resources available to us. But I think we're just more likely to err on the side of, can we just observe this person really closely? Can we try and engage with them a bit more well, proactively, I suppose, to see if we can come to some sort of agreement where they'll let us do it, or is there another way we can keep them safe? So it's just that generally fluffier approach to young people that perhaps on the adult side we don't always think of first. But it is actually one thing through reading. There's our main policy, and the difference is I think the main policy is written by security. The pediatric ED policy is written by a pediatric nurse, ED nurse. And so there's that different spin on it. And their focus is much more about the desirable characteristic that mentioned in the QIP of it should be a clinician who's searching, not security staff. And so it's just a different focus. And actually in the main policy, it doesn't mention, have you considered, can you do something like just watch them really closely? So that is something I will feedback for the team for when it's coming around to be revised. And to be fair, it's really informative. I would probably simplify it slightly, because even though I had to literally read it word for word, I'm sure a lot of people on the shop floor would go, what, where's the summary page? Where's the summary page? And there isn't one. So yeah, the legal frameworks are the same. We just, you know, always try to approach children slightly differently, I suppose, is the basic principle of it.
Thank you.
So if there's no more questions, perhaps we will get 5 minutes back of our precious time. I don't know how everybody feels, but I can't see anyone else's hands up, and there's some great and rich stuff in the chat. So I guess that just leaves us to say thank you. Thank you so much for attending. It's actually a bit overwhelming how many people are on the call. I think it's brilliant that we're all here in this one space to support one another. And I think that we're gonna learn from this and try and do more of it, because it feels brilliant. So thank you so much for giving us your time this morning. Thank you to Mark, thank you to Nirmal for doing all the fabulous work, and the rest of the team around this QIP. And I hope it goes well and is a starting point to try and create a little bit of order out of the chaos that is there for us at the moment.